Okay, I gotta admit, the gram-positive bacilli are some of the most interesting bacteria. I feel there's some really cool things about them. So we're talking mostly about the genus Bacillus here, and there's another genera called the Clostridium. I'm going to talk about really one Bacillus in particular and one Clostridium in particular. But what's most interesting to me about both of these gram-positive organisms that are rod-shaped is that they form spores. We'll say endospores. Okay, so remember we talked about endospore formation very early in the semester. In a normal semester in lab, we would do a Schaefer-Fulton spore stain. This is a really good example of one. Ours usually doesn't turn out quite that well. But in a spore stain, the vegetative cells are pink and the spores take on a green color. So I'll show you in a minute what bacillus would look like if we gram stained it, but we have to do this special spore staining procedure to especially be able to see the spores. Okay, so remember that's pretty unique. Most bacteria are not able to form spores. And remember, this is a survival feature. So the bacillus form endospores in the environment. Okay, so of course we're interested in the ones that are pathogenic. They don't sporulate generally in the host. There is one exception to that, but for the most part, this is when environmental conditions are not ideal, like it's, too cold or there's radiation or low nutrients or whatever. Okay, oops, mistake there. Okay, and what does bacillus look like if we grow it up on a plate? It has a very distinctive appearance. On a typical semester, we use bacillus a lot in the lab. It has kind of a wrinkly edge, and it's kind of wrinkly on top here too. Again, in a normal semester, you would probably learn to recognize that in the lab, but again, this wasn't a normal semester. All right, what else about bacillus in general? They're typically environmental organisms, so by far, most of the bacillus are not harmful to humans. They live in the soil. They're saprobes. So we talked about that term when we talked about our fungi, again, quite a while ago. That means that they are going to get their nutrients from dead organisms. Okay, so the bacilli are one of the many bacteria and fungi that are acting as nutrient recyclers, right? They're getting rid of dead stuff. Okay. Some of our bacillus are sources of antibiotics. Okay, so for example, bacitracin, that's actually the byproduct of one of our bacillus. Okay. And they are aerobes. Okay, so our bacillus are going to be catalase positive. Right, that's just like we use catalase to tell the difference between staphylococcus and streptococcus. We can also use catalase to tell the difference between bacillus and clostridium. Okay. There's on the order of 50 different species of bacillus. There's really only a couple of pathogens. Okay, Bacillus cereus, or B. cereus, there's probably a joke in there somewhere. This species is responsible for food poisoning. In fact, it's typically called Chinese restaurant syndrome because many outbreaks of B. cereus are traced back to some buffet at a Chinese restaurant. Okay, but the one we're going to spend a little bit more time on here, it's a little bit more famous, Bacillus anthracis. Of course, this is the causative agent of anthrax. Anthrax is so rare, really, not only in the U.S., but worldwide. It seems odd, really, to be even talking about it. For example, in the U.S., between the years of 1976 and 2001, there were only 25 cases reported in the U.S. in those 25 years or so. So why do I talk about it if it's that rare? It definitely has the potential to be used by bioterrorists. So because it forms spores, that's a really easy dispersal method. The cells don't have to be live as you're trying to infect a bunch of people. So that's the big worry that, again, some bioterrorist would use anthrax. Okay. Bacillus anthracis has a very characteristic look when we gram stain it. So again, it's purple when we gram stain it, but it has this really boxy cell morphology, all right? I mean, we call them rods, we call them bacilli, but they're much more boxy than what we would normally see for other organisms. And when we gram stain these organisms, the spores really don't show up very well. We can see them a little bit, and of course, when the spore is still inside the vegetative cell, then the spore doesn't take up the dye. That spore coat is just really tough, and it takes some special treatments to get it to take up dye when we do this Schaefer-Fulton stain up here. All right, so bacilli, boxy bacilli in chains. All right, so if we think about the occurrence or the epidemiology of Bacillus anthracis, where do we find it? Reservoir is going to be in the soil. Okay, so remember, the reservoir is where the organism is maintained in the environment. And it's also oftentimes going to be maintained as a spore in the soil, okay? So there are certainly certain areas of the world where that is going to be much more common. So Middle East, I think, is one place, whether it's a little bit more common, Northern Africa, certain areas of the U.S. as well. Now, Bacillus anthracis, anthrax, is typically considered a zoonotic infection. So it's typically considered an infection of farm animals. And if people get it from animals, it's almost impossible without somebody trying really, really hard for a person to pass it on to another person. Okay, so we call it, again, zoonotic because people contract it typically from animals. Okay, so again, people don't transmit it to other people. Okay, so in areas of the world where the spores are more common, typically animals are going to be vaccinated against anthrax. All right, what kind of virulence factors? Capsule. Okay, so not only does it have the ability to form spores, but when it's inside a host, then that's when it forms a capsule. Okay, so when in a host. Okay, so in the environment, typically not going to have a capsule. And here's a nice picture of that. You can see this kind of, capsule around those bacilli. I'm not really sure what kind of method they used to stain that there in that picture. Their capsules are a little bit unusual. We've talked about most of the time bacteria capsules are made of some kind of polysaccharide, some kind of sugar. Anthrax capsules are a little bit different in that they are primarily protein. Okay, so polypeptide composition. Actually, poly-D-glutamic acid, if you're interested in there. Okay, so of course, we know what kind of functions that capsules have. They blocks phagocytosis and helps the organism resist complement. Okay. let's see if I got room here. Exotoxins. Of course, it's not going to have endotoxin because it's a gram-positive organism, but it actually produces 3 different exotoxins. One just facilitates the entry of the other 2 into the host cell. And it's kind of nice, the names don't leave any doubt as to what the toxins actually do. Okay, so edematoxin, okay, that causes swelling of tissues. Okay, so really an uncontrolled inflammation caused by that toxin. And the other is called lethal toxin. Okay, and so you can kind of guess what that does, causes cell death. Okay, so tissue necrosis. And when tissues die off like that, we'll see some examples of what that looks like when you have the kind of anthrax that infects your skin. Okay, so there's actually 3 different ways to contract anthrax, and what the signs and symptoms look like are different depending on the way that you contract it. Okay, so the first way is cutaneous anthrax. Okay, so this is probably the most common form of anthrax, and it's the least likely to kill you. So if you had to get anthrax, this would be the way to go. All right, so cutaneous, that means the endospores enter through a break in the skin. And where would somebody come in contact to those endospores? Again, it's going to be somebody that's working in close contact with animals. All right, so when those endospores enter through some kind of break in the skin, first we get what's called a nodule formation. It's just kind of an abnormal aggregate of cells. And basically we get kind of a slow death of tissues. Those nodules scab over and form what's known as an eschar. Okay, so we can see that down here. An eschar is basically a black scab. So you can get eschars from mite bites. So it's not something that's only for, anthrax patients, but it's kind of a very characteristic thing with anthrax. And oddly enough, as bad as this looks, usually this heals up by itself, probably is going to scar. But the toxins produced by the bacilli have the potential to get in the bloodstream and go systemic. Okay, so if that happens, then someone has about a 20% chance of mortality without treatment. Okay, so again, if you had to get anthrax, this is the best way to get it. So again, I mentioned this already, but it's closely associated with people working with animals. Okay, and again, it's uncommon in the U.S. because, again, we have a really good vaccine for farm animals against anthrax. All right, a much worse way to get anthrax is by inhalation. All right, sometimes we call this pulmonary anthrax. It's also known as wool sorter's disease. Okay, so I think this has been a long time ago, but one of the outbreaks that we had of anthrax in the U.S. was when we got a huge shipment of wool from, somewhere overseas, and it was contaminated with anthrax. A bunch of the dock workers got inhalation anthrax. Okay, so usually from contaminated wool or hair. You picture, shearing sheep, and this is a very dusty, dirty process. Okay, so in this case, again, the endospores are going to be inhaled. And this is the form of anthrax that killed 5 people when those letters contaminated with spores were sent to Congress after 9/11. Okay. And another outbreak that we know about now that was really hushed over at the time, in the late 70s, there was a accidental release of anthrax spores from a weapons facility. I think it was in Siberia, and at least 100 people died. Okay, so 2 phases of pulmonary anthrax. Typically, again, once a host inhales it, typically soon after get what's called a prodromal phase. So we talked about stages of infection. Remember that prodromal phase is when the host has very mild symptoms. So in this case, it's probably going to be flu-like symptoms. Okay. And if a person is treated now, they are typically going to make a full recovery. If they don't have any reason to think that they might have anthrax, though, there wouldn't be any reason to do that. And sometimes those symptoms will stop for a couple days, and then you get a rapid onset of the invasive phase, or sometimes we call this the illness phase. That's when the signs and symptoms are the worst. We see an extremely high fever. Pulmonary edema. So remember that edema toxin, fluid filling up the lungs. So much inflammation that the patient goes into shock. Okay, blood pressure plummets. That lethal toxin is especially targeting macrophages. And that's important because macrophages are one of the big defenses that we have against anthrax. So it's those macrophages in the early part of the infection that are going to go around and try to obviously clear the infection. And if the macrophages are dying, then remember, not only are they, phagocyting cells to get rid of them, but they're a antigen presenting cell. So if the macrophages are dying, they're not able to present antigen to call in the adaptive immunity. Okay, so that's a real problem. 99.9% fatal without treatment, and maybe 50% fatal even with treatment. Okay, so we'll talk about the treatment in just a minute. But of course, difficult, again, for a person to transmit this to someone else, but to transmit it, the host doesn't need to be alive. Say it's an animal, a rotting carcass out in the field, those spores will, again, just go into the ground, into the soil, and another animal that's grazing could, definitely ingest those spores. Okay, so if the spores are ingested, that leads to gastrointestinal anthrax. Okay, so like I said, this is the third manifestation of anthrax when the spores are eaten, and again, the most common way for animals to be infected. All right, so I'll just right there, spores ingested. So humans can get anthrax this way from eating contaminated meat. All right, let's see, what else? We get necrosis, hemorrhaging, tough word to spell, hemorrhaging of intestines. Severe ascites. Okay, that means abdominal swelling. Try to spell that right. Abdominal swelling. All right. So fluid accumulation in the peritoneal cavity. Again, near 100% mortality without treatment. And just like pulmonary anthrax. All right, so what do we do for treating it? Well, we typically give some antibiotics, nothing too unusual here. Penicillin, tetracycline, ciprofloxacin. Okay, trade name Cipro, you might have heard of that, is typically given prophylactically. So if somebody is suspected to be exposed, then everybody they've been, if they have been exposed, maybe they suspect that they have inhaled some, then they would be given Cipro again before they start seeing symptoms. This is a fluoroquinoline, ciprofloxacin. Okay, so but remember when we give antibiotics, that will help kill the vegetative cells, but it's the toxins circulating that are causing all the problems. Okay, there was a monoclonal antibody that was approved in 2012 to neutralize the toxins. So we have made some progress in, again, being able to treat this. Do we have a vaccine? Well, I mentioned we have a good vaccine for farm animals. So effective in animals. And if you are interested in kind of the history of microbiology, it's a really interesting story about how Louis Pasteur developed the first anthrax vaccine, late 1800s. It's got all the, intrigue and excitement. So definitely, again, Louis Pasteur, read about that. It's a good story. Back then they were mouth pipetting. So if you could imagine mouth pipetting live cultures of anthrax, probably, not the greatest job to have. He came up with a attenuated vaccine, which it had problems with, testing to make sure that, it wasn't going to be too harmful to humans. The vaccine that we have for humans today, actually didn't look up what kind of vaccine it is, but our human vaccine, it's not a good one. It only protects for about a year, and you have to have 5 shots over a series of 18 months, and then a booster every year after that. And so typically only people that are maybe in the Army and going to areas, that might be, it's the terrorist threat, right? So if you're in the Army, you might get the vaccine. If you're doing research on anthrax, or maybe you work with farm animals, veterinarians would get the vaccine. But about 1% of the people that get it have really serious side effects. So not just like a little pain or fatigue, but like neurological side effects. So for now, not everybody gets that. All right, so that's anthrax. I just want to spend a few minutes here on Clostridium. So like the bacillus, Clostridium are gram-positive rods. Okay, and they're fairly big rods. This is some kind of, India ink stain or something like that. But you can see also again, able to make the endospores, and you can see that they're terminal here. That helps us kind of identify what kind of organism it is by where the spore forms within the vegetative cell. They are anaerobes. Trouble with my spelling today. So again, they are catalase negative. Remember, that's an enzyme that helps detoxify hydrogen peroxide, a toxic form of oxygen. Okay, they're also considered saprobes, so environmentals, decomposers. We can find them in soil, sewage, vegetative debris. I remember very distinctly when I was in microbiology lab in college, one of the labs, our goal was to isolate clostridium from the environment. And the best place to do that was from horse manure. So one of the TAs brought in all these beakers of horse manure, and just the stench of that just sticks with me to this day. Okay, there are quite a number of species of clinical interest. So some of them are really nasty because they make some pretty nasty neurotoxins. Okay, so Clostridium tetani, causative agent of tetanus, and Clostridium botulinum, botulism, food poisoning. Some years I take time to talk about those in a little bit more depth. We're going to kind of skip over that this year, but you can read about them in your book if you're interested. I'm not going to test you over them this year. Clostridium perfringens is a very actually common form of food poisoning. Okay. So again, all anaerobes, because you're more likely to come in contact with a patient that has C. diff, I thought we would take a little bit more time and talk about that just a little bit more. So I was thinking about it. It's kind of unusual to have the infection have the same name as the organism that causes it, right? So we don't say, oh, I have Mycobacterium tuberculosis. We just say, oh, I've got tuberculosis, right? So C. diff, caused by the organism Clostridium difficile. And this is, where do we find this? This is actually part of our normal microbiota in our large intestine, at least for a lot of people. I think most of us probably have some of that in very small amounts. Okay, it's considered an opportunistic pathogen. And we spoke about this organism before, and we were talking about antibiotics, because this is when somebody is susceptible to getting a C. diff infection. When a host is on antibiotics, and typically it's when a host is on antibiotics for a long period of time, or especially strong, broad spectrum antibiotics, is when this infection is more likely to happen. But it's not just old people. I've had college students that have told me, oh yeah, I had C. diff. It was, it was really rough or whatever. But of course, when you're on antibiotics, that reduces the variety of microbes there in the colon, and the C. diff has a chance to overgrow, where typically that variety of microbes would kind of keep it in check. All right, so it causes a very persistent diarrhea. So one that can be really hard to get rid of. And if it gets a little bit more serious, it can actually cause what we would refer to as a pseudomembranous colitis. And that's just a more serious ulceration. of the large intestine. So can potentially even perforate the large intestine. So obviously the large intestine, it gets perforated, you get all these bacteria, leaking out that are going to cause all kinds of problems. All right, what are the virulence factors that make this organism successful? Again, it's back to the toxins. Toxin A and toxin B, not very, again, originally named. Remember, these are exotoxins. Toxin A is actually an enterotoxin. We've talked about those. Remember, those are toxins that target the walls of the intestine, and toxin B is a cytotoxin. So it's just kind of a general name for a toxin that kills cells. Okay, and together, these toxins cause the death of the epithelial cells lining the colon, large intestine. All right, so increased intestinal permeability is what causes diarrhea. Okay, another structural virulence factor, fimbriae. All right, so remember adherence. So makes the cells able to adhere to those epithelial cells in the colon. Okay, this isn't really a virulence factor here, so let's see, I'll put it out here, but I wanted to mention it, that spores are spread in the feces. So this is kind of the exception to the rule that spore formers don't sporulate within the host. In C. diff, that's not the case. They form spores, and then those spores are passed in that diarrhea. So if you happen to be dealing with a patient that has C. diff, of course, it smells horrendously bad because of some of the fermentations that Clostridium do, but they'll have you really gown up totally from head to toe. Not so much for your protection. Again, somebody is just really, really unlikely to get C. diff without already having been on antibiotics. It's more so you as a hospital worker don't then spread it on to the next patient that you come in contact with, that, the next vulnerable person that may be on antibiotics already. Okay, so it's a toxin-mediated disease. We have some toxoid vaccines that are showing promise in animal models, so it could be eventually that we will have a C. diff vaccine for humans. Right now, what we can do for treatment, usually a person is put on some vancomycin. And vancomycin typically is an antibiotic that's injected. The exception, again, is that if somebody has C. diff, it's going to be taken orally because then it will get to the digestive tract where it needs to be to work. Okay, so sometimes this is effective. Again, it kind of depends on maybe how healthy the host is in general. Sometimes it works for a while and then it quits working and the C. diff comes back. There's a lot of antibiotic resistance with C. diff. So a treatment that I think is really going to gain popularity is the fecal transplant. I know it sounds gross, but you think about it, you've got a patient whose microbiota has been depleted, so how do you get back that mix and variety of, again, mostly bacteria? Well, you ingest somehow the feces of a healthy person. And usually they'll take a relative of the patient and maybe put some of that feces with an endoscope. So the same way that somebody might have a colonoscopy, they'll just put a piece of it in there. And that has been upwards of 95% effective. Okay, so people that, the antibiotics aren't working for and have this chronic severe diarrhea, have a fecal transplant, and bam, they're healthy again. So there is a possibility. This is from a couple years ago, so I don't know if we've made any advances here, but there are clear capsules. The clear ones are the ones that are acid resistant, apparently. So they have put feces in these clear capsules and frozen them, and then patients have to swallow like 18 of these a day or something like this for a few days. So again, if you can get past the ick factor, this is a much cheaper and easier way to do it rather than by endoscopy. And perhaps, eventually that will be the thing. Okay, but this infection is really a huge problem. Over 3 million cases in hospitals every year, lots outside of the hospital as well. So it'll be interesting, where this fecal transplantation goes. There was a setback a few years ago. Somebody had a fecal transplant, and we're learning that we have to screen the donor. There was a problem. Oh, there was an antibiotic-resistant bug that was transplanted, and so we have to do a little bit better screening of, again, the host feces, but it really has promise. All right, thanks for listening.